Yes, I have, and I'm delighted to be with you. And I'll follow up on my friend Senator Cassidy's questioning because we overlap quite a lot on this. I've been a supporter and defender of MedPAC and worked very hard to make sure that CMMI and ACOs got into the original Obamacare bill. And I'm kind of an amateur delivery system reform advocate. So that's where I'm coming from. And I will send all of you a copy of my handy dandy favorite graph right here, which shows as a top line the original predicted federal healthcare spend by CBO in 2010 for the 2010 to 2020 decade. And then it tags onto the end of that the prediction for 2020 forward. And then you compare that to actual. And what happened with actual is it came in well below the projections. Even with COVID surging healthcare costs, it came in still well below the projections. And in the next 20 years, the projection are that compared to the original baseline, we're going to save $6 trillion in federal healthcare spending. And I contend that that comes from delivery system reform, triple aim, ACOs, getting off of fee for service, all the stuff that we've been talking about. And I would like to make sure that we revive that conversation and figure out what we can do to improve ACOs. We have two of the champions, both in Rhode Island. One was Coastal Medical and the other was Rhode Island Primary Care Physicians. They're now integrated into larger organizations, but that's how they did the ACO work that made them best in show nationwide. And so those are the names I still think of them by. But we had really, really, really good results with ACOs. We're trying to get CMMI to go along with a Rhode Island-based sort of mini statewide ACO type thing for advanced care patients, end-of-life care patients, whatever you want to call them. Because there's some very stupid things that Medicare does with payment. If you're in that point in your life and in your care, to free it up so that that's more patient-based also. So I'm really interested in following up this conversation to see what your best recommendations would be to do, ACO 2.0, to see where we should be pushing CMMI. Liz Fowler used to be here in this committee and was the Chairman Baucus's lead staffer during the Affordable Care Act proceedings. So she knows this history very, very well and is very able. So I think we've got a big opportunity. And as Bill's questions and mine, which I think you could basically switch other than the Rhode Island state references, and you couldn't tell who asked them, this is really bipartisan. And even at our bitterest, repeal Obamacare, don't you dare, repeal Obamacare, don't you dare battles, the ACOs, CMMI, delivery system reform, all of that was safe, was unchallenged, was winning and percolating and doing well, both in red and blue states. So my purpose in showing up is to enlist all of you in giving advice to this subcommittee as to what we should be doing to push that $6 trillion number to maybe a $7 trillion number, maybe even 10 trillion, because we've seen over and over again how better healthcare decisions save money, in addition to making patients feel better and generally making doctors feel better about their work. So I think there's a lot of opportunity here, and I'd like to ask all of you to pitch in and help us seize the next level of those opportunities. And if you have specific thoughts, you've got 49 seconds. Do you agree that this is a good place to go, at least?
Sheldon, can I interject for a second? Because Sheldon and I have talked about this a lot. And I was going to follow up with a question. Senator Daines allows me to go a minute more. Senator Whitehouse is pointing out that in the case of Medicare Advantage, it is anchored to an unenrolled cohort. So the MA plan can improve, but it still makes a profit because it's anchored to an unenrolled cohort. So Dr. Chernew, this may be a question for you. Whereas ACOs, the more they save, the less margin there is to save, and so therefore their upside becomes less and less. If you will, it disincentivizes further improvement. So I think, Sheldon, that's what I've gathered your concern is.
We had some jolly wars with the Obama administration about punishing rather than feeding the lead dogs, and basically trying to get them into a situation in which no further gains could be extracted. And even if they were way more efficient than their like next door physician groups, they would be punished for that. So there were some very unfortunate decisions that were attempted to be made during the Obama administration, but I think we fended off the worst of them, and it all actually turned out pretty well, although it was a lot of hard work for the ACOs to plow through that.
So, Dr. Chernow, is there a way, as you know, Sheldon presented the problem, as I kind of elaborated my interpretation of it, is there a way to address the fact that it's a diminishing return for the greater quality you get?
So first, thanks both of you for your question, and actually I enjoyed listening to your discourse. Let me start by saying that it's pretty widely acknowledged that there's inefficient care delivered in the fee-for-service system, and that the fee-for-service payment model is not well suited to get rid of a lot of that inefficiency. And I think, as you both were discussing, the ACO type programs offer some promise. MedPAC in general has been very supportive of this direction of payment reform, and we have been actually having discussions about exactly how to solve that problem with benchmarking. We call it the ratchet effect. The better you do, the less you get paid in the future. And we will be having a report published in June to address that specific issue. The sort of foreshadowing and result is, yes, I do believe there's ways in the regulations that you could address that problem, or more broadly speaking, payment reform is particularly important. The trick is to get the regulations right to provide the incentives for efficient delivery of care and maintaining access to high quality care. What we've seen so far, I think, has been success of alternative payment models, but honestly, not a ton of success. And through, I believe, appropriate changes to regulation that MedPAC is now discussing, we can do a lot better and make sure that the way in which we pay providers is not an impediment to the efficient delivery of care that we need if we're going to maintain fiscal sustainability of the Medicare program.
Okay.
Can I tell my favorite illustration of this? So we have an insurance company in Rhode Island, Neighborhood Health Plan, that deals with a lot of the lower income population, Medicaid and so forth. And a new CEO came in and he went through all their frequent flyers at the emergency departments and sent social workers to go talk to all of them. And one social worker came back and said, "Hey, boss, I think if we buy this guy an air conditioner and a TV, we can probably reduce his appearances in the emergency department quite a lot. He's running about, $230,000 a year now because he's got a few conditions, and when he goes in, they find something and they got to deal with it, and around you go. But he seems to be going in just because he's hot in the summer and lonely." So they said, "Yeah, here's, a couple $100, go to Walmart, get an air conditioner, get a TV." And sure enough, he went from, I'm making up the numbers now, but 20 emergency department visits to 2, and they saved hundreds of thousands of dollars. Now, it's really hard to create air conditioners and television as a benefit. It's really inefficient to do that. But if you let people who know the patient make some choices like that, and you allow the cost, if the poor social worker had to buy the TV and the air conditioner herself, that would be pretty expensive.
Okay, Sheldon, I got to move on to Senator Daines, man. You're 4 minutes over, and he's been patient.